So now coming on to male infertility, approximately 4% of all infertile men are now diagnosed to have a genetic cause, but a majority, that is 60 to 7%, remain without a clear diagnosis and are classified as unexplained. This could be, of course, due to the lack of awareness or a lack of a correct or a newer testing that is present. This is the kind of contribution genetic testing has in male infertility. Now, coming on to the important factors or important groups for male infertility. Number one is the hypothalamic pituitary axis dysfunction. We of course know that the starting of all the hormones are from the hypothalamus pituitary axis. Second is the quantitative spermatogenetic defects. Third is the qualitative spermatogenetic defects. And finally, we have certain obstructions or dysfunctions of the vas deferens, that is known as a ductal obstructions. So whenever there is male infertility, we think of these causes and then we can decide or even advise urologist what test to do. Genetic testing is not indicated for all infertile men. This is a little in contrast to women, in which we do a karyotype for all because it will give us certain crucial information. So when do we not do genetic testing? So as a geneticist, it is difficult for us to say that there are certain places where you will not do genetic testing. Of course, when number one, there is a history of a previous established fertility by this man. Second would be when there is a known prior gonadotoxic exposure that was present. It is not very easy actually to take the history of this, like a mumps infection, etc., because these histories are a little vague. But if there is a prior chemotherapeutic exposure or a radiotherapeutic exposure or an infection, then we do not do genetic testing, basically when we know a cause. Third is when the examination is really suspicious for an ejaculatory duct dysfunction. So in these cases, we do not do a full genetic workup. So now I will come on to the different guidelines by different societies, by the European American societies, that when do we do which test for a man. So let's just focus maybe on one guidelines that is possible. These are the three main tests that we do for men. Number one is the karyotyping. We do a karyotyping when there is a non-obstructive azoospermia with a count of less than 5 million. So all men in which there is a non-obstructive azoospermia with a count of less than 5 million, we do genetic testing. Then we have when do we do a Y chromosomal microdeletion. So as I showed a diagram of the Y chromosome, which I will again show. So I'll just show again the diagram of the X chromosome, Y chromosome. So here is the Y chromosome. And when we are testing for male infertility, we need to look at the whole Y chromosome, because most of the factors for male infertility would lie on the Y chromosome. Now, three important parts of the Y chromosome that we need to be aware of is the sex determining region of Y, and these are the three factors, that is the azoospermia factor related A, B and C, that are present, and we have to test for these factors. Now, which test do we do? So when we are suspecting that there is a lot of azoospermia that is present, we need to check for the presence or absence of these factors. Now, to check for the presence or absence of these factors, as I said, we cannot do a karyotype, because a karyotype will not pick up such small deletions or duplications. And the test for this could either be a chromosomal microarray or another test which we call as MLPA, that is the multiplex ligand probe amplification test. This MLPA test will pick up these deletions or duplications. And for the SRY region, we do a FISH, that is a targeted testing for SRY region. So now coming back to the different tests that we have to do for male infertility, if there is one slide which will tell us everything, it is this. We do a karyotype when there is a non-obstructive azoospermia of less than 5 million. And also we look at Y chromosomal microdeletions, and the test that is done for Y chromosomal microdeletion is either a chromosomal microarray or an MLPA. About the cystic fibrosis testing, I will just come on to in the next slide. Now coming on to the different disorders that can be present in male infertility. One of the disorders that can be present is the congenital absence of vas deferens. If on ultrasound or on examination we find that there is an absence of vas deferens and there is no prior radiotherapeutic exposure, we think of a genetic disorder which is known as a cystic fibrosis. Cystic fibrosis is a genetic disorder which can present in many forms. It is an autosomal recessive disorder, that is, both the copies of the CFTR gene which causes cystic fibrosis have to be non-functional for this disorder to happen. It is just like thalassemia, that is, the parents are carriers and the person who has the disorder will have both the mutated copies, just like thalassemia. So, cystic fibrosis is a disorder in which, in addition to congenital absence of vas deferens, people can also have recurrent infection, pancreatic infertility, and of course, male infertility. Cystic fibrosis is a very common disorder in India, and the carrier rate would be around 1 in 50 that is present. Now, when do we think about congenital absence of vas deferens? Can we look at the semen analysis and think about it? So when there is a severe oligospermia or a severe azoospermia, and when there is a low volume of ejaculated semen with a specific chemical profile, the most important factor to suspect a congenital absence of vas deferens would be a low fructose concentration. Whenever there is an obstructive picture or there is a congenital absence of this duct, the fructose concentration would be less. Of course, we can remember that there is all these parameters as well. There is a low pH, there is an elevated citric acid concentration, elevated acid phosphatase, but the most important is the low fructose. In presence of oligo or an isospermia, if the fructose in the semen is less, we think of this disorder known as cystic fibrosis, also known as congenital absence of vas deferens. So, congenital absence of vas deferens can affect one, that is the unilateral vasa, or both the vasa differentia. Bilateral absence occurs in 2 to 10% of all infertile men, but accounts for 40% of obstructive azoospermia cases. So, if we have obstructive azoospermia, 40% out of these which will actually have a genetic disorder, that is cystic fibrosis. So, over 90% of men with congenital absence of vas deferens have morphologically abnormal seminal vesicles also. Physiologically, this results in abnormal semen parameters that we have already discussed. Nearly 80% of men with congenital absence of vas deferens will have mutations in the cystic fibrosis gene, and the name of this gene is the CFTR. So whenever there is an obstructive azoospermia, we do this testing. Now, when you see a semen analysis report and there is a non-obstructive azoospermia, we think of doing these tests. That is a karyotyping and the deletion of the azoospermia factors on the Y chromosome. But when there is an obstructive azoospermia, we do testing for CFTR. If these two basic big rules we can remember, this really summarizes our male infertility causes. Now, this congenital absence of vas deferens is most commonly associated with cystic fibrosis, and it is caused by mutation in the CFTR gene. And the diagnosis is established in a male with the following features, that is azoospermia, absence of vas deferens or palpitation, and identification of mutation in the CFTR gene. Now, what test we do for CFTR gene? Again, we do an NGS based test, that is, we do an exome sequencing or we can even sequence the CFTR gene itself. Basically, it is a gene-based test. Now, as I was speaking, this test has an autosomal recessive inheritance. That means when two people who are carriers have a child, there is a 25% of this child having the disease. For example, this woman is a carrier and this man here is another carrier. So if they both have one mutation each, there is 1 in 4 chances that their child will have cystic fibrosis, or there is a 50% chance that the child would be a carrier and a 25% chance that the child will not get mutation from any parents. As I mentioned, it is exactly like thalassemia. So now when one of the parent has cystic fibrosis, this scenario changes. So what is the implication of this testing? Why do we do these testing? So very interestingly and encouragingly, these men who have congenital absence of vas deferens, they just have an obstructive block and they typically have normal spermatogenetic potential and are therefore excellent candidates for ART. So, because the sperms are not able to come out, there is a low fructose content and there is azoospermia. And because they are not able to come out, they are all lying inside safely. And once we can take out those sperm by TISA or whatever other techniques, they are good candidates for artificial reproductive therapies. So men with CBAVD should instead also undergo renal imaging due to high incidence of other causes of renal agenesis also. This is a little unrelated and more of a genetic finding. Partners of men with CBAVD should be tested for the same disorder to assess the risk in the offspring. Again, if a man is found to have a cystic fibrosis, his partner should also be tested to understand the risk to the next generation. And of course, once we understand those risks, we can offer them IVF with pre-implantation genetic testing, and we can also offer them a prenatal genetic diagnosis. So again, this is the summary of what we have spoken. When we have a man with cystic fibrosis, we should test the woman also and then offer them different techniques of the same testing. So now most of the cases of congenital bilateral absence of vas deferens are caused by the CFTR gene. That is, that one gene is responsible for most of them. But as genetics evolves and so do all of us, so there is now another gene that has now been known to also cause CBAVD. This gene is known as the ADGR2. So nothing much that changes for us as gynecologists. Now we can order exome sequencing, that is the gene-based testing for these men. That exome sequencing will pick up mutation in the cystic fibrosis gene and also this new gene that has been discovered. So now coming back to this really beautiful small chromosome called the Y chromosome. So these are the region that I will again speak about, the sex determining region of Y and the 3 important parts of the Y chromosome, Y arm of the X chromosome. So any deletions in these azoospermia factor regions here, AZFA, AZFB or AZFC, they can be associated with spermatogenetic failure. So who do we test for these deletions? Do we test everyone? No, we do not test everyone. We test only men who have a non-obstructive oligospermia of less than 5 million count. So 7.5 of all oligospermic and azoospermic men in fact have this deletion. So you order testing for this deletion in men who have oligo and azoospermia of the non-obstructive type. So now due to the high frequency of these deletions, both the ASRM and the European guidelines recommend offering Y chromosome, this YCMD means Y chromosome microdeletion, to all men with sperm counts less than 5 million per ml. So which test to do? I spoke about 2 tests. We can either do a chromosomal microarray or we can do an MLPA based testing. So what do we do in genetics? Once we have found this deletion, what do we do? Genetic counseling must also be considered for men who have been found to have these deletions, as these deletions are necessarily transmitted to all male offspring. Now these deletions are present on the Y chromosome. All the sons of this man who has this deletion will also have this deletion. So even if by some technique, when we are able for him to father a child, we have to tell them that if he has a son, the son will necessarily carry this deletion, and his son may be infertile also, or subfertile, however, the whatever the word we want to use. But also sex selection for this disorder is not possible. So sometimes they tell us, then ma'am, can you just have help us to have a daughter? But that also is not possible. Although men with AZFC deletions have fathered sons via ICSI, the spermatogenetic and reproductive capabilities of these children are not known. However, there is a thought to be a spectrum of infertility ranging from sterility to some spermatogenetic potential that is present. Now, when we see that these three regions could be deleted, if this AZA and AZB, if one of them are deleted, then we have seen more of sterility. And when this AZFC is deleted, there is a better spermatogenic potential that is found. Now we have Klinefelter syndrome. I think we all are very well aware of Klinefelter syndrome, which is the commonest disorder of male infertility. Is like the counterpart of Turner's in females. Klinefelter syndrome is the result of two or more X chromosome in a phenotypic male. The clinical phenotype was first described in males with tall stature, small testes, gynecomastia, and azoospermia. So you will have very tall, little hefty males, who will also have gynecomastia and will have azoospermia. A simple test to do will be a karyotype. Extra X chromosome lead to testicular hyalinization, fibrosis, testicular hypofunction, which results in genital abnormalities, usually hypogonadism and infertility. And early testosterone supplementation is considered, and this early testosterone supplementation helps them attain puberty, helps them have a male phenotype that is present. So this is a karyotype of a Klinefelter syndrome. As we see that this is a small Y chromosome and there's an extra X chromosome. So this is X, X and Y. XXY is a phenotype of these this is the genotype of these individuals. So when do we suspect Klinefelter? We have tall males with gynecomastia, infertility, and some sort of aggressive, depressive, and intellectual, some sort of intellectual disability is also present in these individuals. How do we test for Klinefelter syndrome? The same way that we test for Turner syndrome. We can do a FISH for XY testing. So as we can see here, these signals, that FISH test is the fluorescent in situ hybridization. In this case, there are two signals for X chromosome and one signal for Y chromosome. So this is an XXY FISH. XXY stands for Klinefelter syndrome. So the advantage of FISH is we get report in 2 days, and we can do a karyotype also, which will show, which give us reports in 3 weeks. So now finally, I would like to end my talk with ending with the pituitary hypothalamic axis, which shows that throughout the system of a male, starting from a hypothalamus to pituitary, through the adrenal to the urethra, then coming down to the reproductive organs, that is the testes, finally the Sartori cell defects, the premeiotic defects, the spermiogenetic effect. There is a genetic correlation that is present in every part of the body. So how do we not do the testing for it? And so there are 3 colors in which the genes are shown: the maroon color, the orange, and the light orange color. The ones in the maroon are shown to have 100% definitive correlation, and these are disease causing genes. So the ones in maroons are the ones we test for and we find a definitive cause for. A common one I'll discuss is the anos one here, and we all know that if there is decreased smell and infertility, we think of this anos one gene related disorder, which is also known as the Kalman syndrome. So, Kalman syndrome is a cause for infertility, and it is caused by this NOS1 gene, which functions in the hypothalamus. So, if we want to look at all the genes in a man, we can do an exome sequencing also. So now there are certain specific genes. When we explain to our patients, we can tell them that there are certain specific genes which are related to certain specific abnormalities. If there is anosmia, we look for Kalman syndrome. If there is deafness, we look for CATSPER2 gene. So this test together can be done by exome sequencing. So what is the utility of all this testing? We can have a better personalized treatment and improved risk assessment for transmission of infertility to offspring, better counseling potential for the health risk in infertile male, for azoospermic men prior to a testicular biopsy. Finding a genetic diagnosis may help in predicting a chance for successful testicular sperm extraction is present or not. A very, very important point that remains is once you have a diagnosis in one person in the family, you must do counseling for other brothers, sisters, cousins, what is known as a cascade counseling, so that we can also pick up these genetic disorders on time. And what we need to do is delve into the depth based on the type of defect, and we can only decide which genetic testing is indicated on a case to case basis. Family history is extremely important and is to be sought in each case, like the family history of mental retardation in Fragile X. This aids in a definitive diagnosis, it aids in giving a risk to the family, and there is, of course, no single test that I can say can be done for all patients of male infertility. But to summarize, if you have a non obstructive azoospermia, you do a karyotype and we do Y chromosomal microdeletion, and when there is an obstructive azoospermia, we test for cystic fibrosis gene mutation. With that, I thank you, ma'am, Sharna ma'am, for this opportunity. It was a pleasure and really a good for me to present today. Thank you, ma'am.